Good afternoon. I'm Leslie Prichep, and I'd like to thank the organizers for giving me this opportunity to present to you today on an objective assessment of concussion using an electrophysiological-based multimodal biomarker. I'm the Chief Scientific Officer of BrainScope and an inventor on intellectual property licensed by BrainScope from NYU School of Medicine. Dr. Jeffrey Brazarian's institution, University of Rochester Medical Center, received research support from BrainScope as a subcontractor on the DoD contract supporting this work. He is also a member of the advisory board for Abbott and Q30 Innovations. This presentation only reports results of an independent prospective FDA validation study to which we were blinded. The validation study was the second phase of a more than 4-year DoD-funded research contract from the U.S. Department of Navy. The views, opinions, and findings contained in this presentation are those of the presenters and should not be construed as an official Department of Navy position, policy, or decision. Here on the left, you have our BrainScope team. And if I were to ask you to think of one person in this group and to give me information to help me identify that person, no one feature can describe a specific individual. You'll need to identify a unique set of features that are distinctive to that person or a specific group of people. Concussion results in a set of changes in brain electrical activity, or the EEG, that can be identified by an algorithm describing that distinct profile. While CT remains the gold standard for TBI for intracranial bleeds, functional brain injury or concussion is not visible on CT. We look here on this image on the left that I borrowed from NICO. We see a scan from a concussed patient, and on the left, their CT scan, which was read as normal, and on the right, an MRI SWI scan that showed multiple lesions. So concussion can be seen with advanced neuroimaging tools such as this and MRI DTI and with EEG. The BrainScope Concussion Index is a multivariate, multimodal marker of concussion with EEG at the core. Before I go further, I'd like to point to 3 important factors that contribute to the expanded clinical utility of EEG today. The first is the revolution in technology, due largely to the advances in cell phone technology, that allows EEG to be acquired on a handheld device and processed in real time. The second, advances in signal processing, have enriched the measures that can be used to characterize the EEG signal. The third is artificial intelligence that enables sophisticated machine learning algorithms to be used for prediction and classification. Leveraging these advances, BrainScope uses EEG at the core of its classification algorithms. How do we get from EEG to classification? This is going to be the 10,000-foot view. Starting on the left, 5 to 10 minutes of EEG data are acquired from the frontal and frontotemporal regions of the forehead. In real time, a suite of artifact algorithms are used to identify and remove non-physiologic signals which are produced by eye movement and muscle movement and others, and can contaminate the EEG signal. From this artifact-free, clean signal, some 10,000 features are extracted describing characteristics of the EEG, including, for example, those describing connectivity between regions and changes in the frequency spectrum. Each of these features are then regressed relative to age-expected normal values, removing the effect of age, and expressed as z-scores for all further statistical analyses. The same approach is used to incorporate features from other modalities, such as that from neurocognitive performance tests. Informed data reduction is then used to reduce this large feature pool prior to becoming candidates for the machine learning algorithm in order to reduce the risk of overtraining and thereby increase the likelihood of independent replication. The reduced feature pool from a large population of subjects then serves as the input to the machine learning methodology, the output of which is an equation representing the weighted combination of a subset of features which maximally separate the groups of interest. The concussion index was derived using machine learning and advanced classification methodology, a genetic algorithm. It was based on a large population of injured and controlled subjects, 535, with longitudinal evaluations for a total of 1,875. The algorithm identified the set of features which, in weighted combination, maximally separated concussed from controlled subjects. Using the ROC curve, a threshold was determined and pre-specified for use in this validation study. For these purposes, less than or equal to 70 indicates likely concussed. The EEG features which contributed most to the concussion index are those reflecting the underlying processes associated with the physiology of concussion, most importantly, EEG measures of connectivity. Connectivity reflects neuronal transmission between brain regions and includes EEG measures of coherence, phase synchrony, asymmetry, and others. In addition, with the increasing recognition of the need for multimodal assessment in the clinical diagnosis of concussion, the concussion index includes neurocognitive performance and vestibular information. However, EEG is the largest contributor to the algorithm. Let's turn our attention now to the FDA Validation Study, the primary aim of which was to demonstrate efficacy of the concussion index in a prospective independent population using the pre-specified algorithm and threshold. The population consisted of 580 males and females, ages 13 to 25, for a total of 1,318 evaluations. The concussed athletes had witnessed head impacts and were removed from play by site guidelines, all of which followed NCAA and Berlin consensus recommendations. And they were conducted at 10 U.S. clinical sites. The protocol included evaluations within 72 hours of injury, day 0, at clinically determined return to play, and 45 days after return to play. Each evaluation included a 10-minute recording of EEG from the frontal and frontotemporal regions of the forehead using a BrainScope device and a disposable headset. Neurocognitive performance tests and clinical symptom assessments, as well as concussion histories, were all included at each time point. Population characteristics are shown here. There were 207 subjects in the concussed group and 373 in the control group. Equivalent ages are seen with 19.36 in the concussed and 19.60 in the controls. 59.9% of the concussed population were males and 51.2% of the control population. GCS in both populations was 15. The total SAC score was 26.09 in the concussed and 27.58 in controls. The concussion symptom inventory was 27.4 in the concussed and 2.28 in the controls. The concussion index on day 0 was 32.72 in concussed and 74.99 in controls. Further, we divided the concussed population into 2 subgroups based on how long the interval was between injury and return to play, with a rapid return group of less than 14 days, representing 43% of the population, and a prolonged or protracted return group of more than or equal to 14 days that represented 57% of the concussed population. High accuracy was obtained in identifying the likelihood of concussion at the time of injury, with sensitivity of 85.99%, specificity of 70.78%, a negative predictive value, or NPV, of 90.1%, and a positive predictive value, or PPV, of 62.02%. The area under the curve, AUC, was 0.89. Let's dig into the results a little more. Here we see box plots on the left for the controls and on the right for the concussed population. at 3 different time points for day 0, time of injury, return to play, and return to play plus 45 days. Let's first look at, the concussion index at the time of injury in the concussed population. We see that it's well below threshold, demonstrating high sensitivity to the likelihood of concussion. We know from the prior slide that was with 86% accuracy. Second, the CI at day 0 was significantly lower, more abnormal, than the CI at clinically determined return to play, with a p-value of less than 0.0001, supporting the fact that the CI reflects recovery. If we look now at the control panel, we see that the controls was significantly stable over time. And thus, change in the CI, when seen in the concussed population, could be reliably interpreted. At return to play, the concussed group had returned to CI levels seen in the controls, with 80% of them within the normal range, supporting the use of the CI to aid in RTP decisions. Further, since some of the concussed, 20% in this case, were returned to play but were still below threshold, showing a CI that indicated likely concussed, which may indicate that this subgroup had evidence of brain function impairment beyond the point of resolution of self-reported clinical symptoms, further supporting the fact that as an additional piece of objective information in the evaluation of readiness to return to play, the concussion index could contribute important information. Let's turn our attention now to tracking with severity and recovery. Looking now at the 2 subgroups we identified, on the left, the concussed with returns in less than 14 days, the rapid returns, and the concussed with prolonged returns of greater than or equal to 14 days. Here we're looking at 3 different time points: time of injury, day 5 following injury, and return to play. I want to note that day 5 comes from the algorithm development phase, but was independent of that used for the derivation of the CI, which used only day 0. Let's start by looking at the time of injury, and we see that both groups are significantly below threshold, but that the concussed with rapid recovery have a higher CI than those with prolonged recovery, reflecting the fact that severity can be seen in the CI at the time of injury and suggesting the potential to predict outcome. At day 5, those with rapid RTP have higher CIs than those with prolonged RTP, demonstrating that change in CI is tracking with recovery. What's the correlation between symptom burden and the concussion index? This became an important question to the FDA, and so using the total score and the CSI as an estimate of total symptom burden, we looked at the correlation between that value and the concussion index. And we found highly significant correlations between this estimate of total symptom burden and the CI score, with a negative correlation of 0.7971, which has a probability of less than 0.0001. The lower the CI scores were predictive of lower symptom burden. The CI, however, has the added value of being objective, replicable, and not subject to gaming or learning. Last important fact was the investigation of what changes in CI might actually be correlated with in terms of changes in brain activity. Wild and colleagues recently published findings comparing neuroimaging results in concussed athletes with that of the CI. And they found significant correlations between the CI and DTI measures. As the DTI measures got more abnormal, the concussion index was lower or more abnormal, suggesting that changes in white matter integrity were reflected in the concussion index. The 2 examples that I choose to show you here on the left from the Wild article, the top one is for the mean diffusivity in the left inferior frontal occipital fasciculus, and the bottom, FA, in the left interior longitudinal fasciculus. I picked these 2 because it's important to demonstrate that the correlations with CI were independent of the distance from the recording electrodes of the fiber tracts, again supporting the fact that the changes in white matter integrity seen even distant from the recording electrodes were reflected in the CI. In summary, the findings from this validation study demonstrated that the CI showed high accuracy in identifying concussion, can add an objective component to assessment of recovery and readiness to return to activity, can reflect severity at the time of injury, and is predictive of total symptom burden. The results of this validation study supported BrainScope's submission to the FDA for integration of the Concussion Index into the BrainScope device, which was cleared in September of 2019. Details of the study are reported by Bazarian and the PIs from the study, which is currently in review. But I want to end with a key point made by the authors of this article. As an objective, reliable indicator of the presence of concussive brain injury and readiness to return to activity, the Concussion Index has potential to aid in clinical diagnosis and reduce long-term concussion-related disabilities. I want to thank our funding source, the U.S. Navy, for supporting this research, and we gratefully acknowledge the athletes who volunteered to participate in the study and the research staff from all the clinical sites listed here on the left. And I feel I would be negligent if I didn't end by saying to any of you who have not yet gone out and voted, please, it's important. Vote. Thank you for your attention.